Okay, so look, thank you so much for the opportunity to be here. I've had a great day and a half. We had a workshop yesterday, which was just a fabulous day where we shared ideas and we talked about a number of things in terms of how we deliver psycho-oncology care. So if you think, what is psycho-oncology? Psycho-oncology is a fairly new discipline, established in 1984 in America by Jimmy Holland and a group of interested clinicians. So it really attends to the psychological, social and emotional aspects of cancer for patients and their carers. And it's really along the whole course of the trajectory, so from diagnosis, recurrent disease or death. One of the things that we talked about yesterday is the fact that although we've got the best survival rates in the world, people do still die from cancer, and we need to be able to be responsive to those people who are facing terminal illness. Now, one of the problems with psycho-oncology and psychology and psychiatry generally is that people think that anyone can do it. There's actually a bit more evidence to it behind that. So I think when we're looking at psycho-oncology and psychosocial care, we need to make sure that we're providing an evidence-based product. How do we actually evaluate quality? Now, there's been some work in the UK, the National Institute of Clinical Excellence and the Psychological Society have developed a number of strategies to try to evaluate if services are providing quality. However, they're very hard to capture, the metric. We actually talked a lot about this yesterday. How do you capture a metric? If you're looking at a drug trial, you've got survival as an outcome. You've got quality of life, walking, talking, eating independent and self-cares. How do you actually capture some of these outcomes? And they're very difficult. Is the service timely and responsive? We can measure the time from referral to seeing a specialist, but are they offering effective interventions? How do we know unless we're doing really rigorous evaluations? It's very complicated. In the US, there's been a strategy to develop a cancer matrix tool. And this tool is actually rating the services people provide from 1 to 5. So services are completing this tool and they're saying, no, we're not doing this at all, to 5, yes, we're doing this on several fronts. But you can see that these are soft measures. Yes, we have communication skills training. Does that mean people go? Does it mean that they're better communicators? We don't really know. Now, today is about innovations, and I want to talk about an innovation from Cancer Australia. So, Cancer Australia has established a mechanism for regular reporting of national cancer control indicators, and that provides the ability to target policy or modify activities. So that means that you can promote best practice care, reduce inequalities. You can also identify areas where we're not performing quite so well. You can highlight capacity and strengths. So the National Cancer Control Indicators Framework, you'd be all aware that we have data about how many people smoke, about level of physical activity, about whether people get timely access to surgery or treatment. But the Cancer Australia has recently convened a working group to develop psychosocial indicators. So that is highly innovative. And as usual with Cancer Australia, it was a highly rigorous process. And so the psychosocial indicators that they're working on now are patient experience and screening for distress. So I think that that is a powerful message that psychosocial care is part of mainstream cancer care. And I think it will be important to see how that goes as that's rolled out. Now, if we think about innovations in psycho-oncology, what are some of the emerging themes? What's actually going on? Well, one of the emerging themes is low-intensity interventions. And so a study conducted across a couple of sites was called Beating the Blues. And this was a randomised trial of low-intensity approaches for distressed patients. So these were people who called Cancer Council care lines, and they either had a single nurse-led session or 5 sessions delivered by a psychologist. If we actually look at the literature in psychotherapy and treatment of anxiety and depression, many of the interventions are very intensive, which poses a burden for patients who are physically unwell. It also maybe increases stigma, and it may reduce compliance. So this was a low-intensity intervention. And the measures were the impact of events, looking at traumatic impact, measures of depression. Now, unfortunately, this was really, I guess, what we would call a pragmatic trial. There was no control group. What they found was that there was an improvement in both groups over time without a control group. However, there were very high retention rates, and that suggests that a telephone-delivered intervention may be highly acceptable. The patients with lower education benefited more from the intervention provided by the psychologist. What are some of the other emerging themes? Well, one is internet-based interventions, and we talked a good deal about this yesterday in our workshop. So increasingly, there are CBT-based interventions that can be delivered online, and some of these can be moderated. So you can have people be given information, complete homework, and then that's moderated without necessarily having a face-to-face contact. Now, a review of trials by Griffith has shown, this is 26 trials of internet interventions for depression and anxiety, not in people with cancer, so depression and anxiety, and the duration ranged from 1 to 13 weeks. Mean therapist time was 155 minutes, and 23 demonstrated some effectiveness compared with controls. So one way of innovating and building capacity, particularly in a big state, I was horrified to hear that the drive from Brisbane to Broken Hill is 14 hours. You know, we've got a paucity of highly skilled psychosocial professionals outside the capital cities. The majority of specialists are located on the eastern seaboard. So internet-based interventions provide a very real opportunity to be able to extend our capacity, and they're likely to be highly acceptable to patients. Now, one of the things that we talked about yesterday, and it may surprise you coming from a psychiatrist, because I guess we're often thought about as providing treatment for people who are severely mentally ill or anxious and depressed. And I personally think that we don't pay enough attention to things that are non-disorder. And so I think that increasingly we need to think about how we actually might prevent disorder, or how we actually respond to people who have mild distress and fulfil their needs. Now, this becomes one of the problems, of course, in capturing metrics. If we're treating people who are depressed and we prove that we have a good outcome, well, that's fantastic. But what about the people who actually suffer? How are we helping them? So Sylvie Lambert and Afa Gerges have been looking at an internet-based intervention called Coping Together. And this is really a couples-based intervention, and that is a highly innovative thing. Increasingly, we're seeing that family members and carers are affected by the cancer experience. So including couples in an intervention is highly innovative. There's no data from this yet, but certainly the workbooks are very practical, and preliminary pilot work suggested that the nature and format of this sort of intervention was highly acceptable. Another RCT of an internet-based intervention was conducted by Lisa Beattie here in Australia. I would have to say that in Australia we have a small population. We have a fairly small psycho-oncology research population, but really our productivity has been amazing. Jimmy Holland, who established IPOS, the International Psycho-Oncology Society, has long said Australia punches above its weight, and I think we certainly do. So this Finding My Way internet-based intervention was open to all patients who were being treated curatively for cancer. Recruitment was conducted online. That's an innovation. They had 6 modules, and they covered starting treatment, how to make treatment decisions, coping with physical symptoms related to treatment, emotional distress, coping with body image changes, family and friends and their issues, and completion of treatment. Now, it's a small study. 20 people were randomised to each arm, but there were effects for cancer-related distress, global quality of life, physical function, role function, and anxious preoccupation. So what I'm suggesting is that the internet might provide a way to provide increased capacity, that this can be successfully delivered for people who have disorders such as anxiety and depression, But these things can also be provided for people to help them navigate the system and perhaps even present the onset of depression. Now, one of the big emerging themes, I think, is how we can be more collaborative and how we can look at pragmatic interventions. So one of the discussions we had yesterday was how we actually treat people who are depressed. Now, I'm presenting this as though this is highly new, but in fact it's not. Wayne Caton has been publishing on this for many, many years. He died last year, but he really led the way in researching the interface between medical conditions and psychiatric conditions and how we could maximise functioning in terms of medical condition control and how we could reduce depression. So this most recent study was of 214 patients with poorly controlled diabetes, heart disease and coexisting depression. And they conducted that across 14 primary care clinics. And basically what they used was a medically supervised nurse. So the nurse was working with the patient and with the family care physician. They had structured interventions. They were looking at promotion of self-management, evidence-based treatment protocols, and close follow-up. And there were significant improvements in diabetic control, hypertension, and depression. I think one of the complexities of psycho-oncology is that we need to be aware that physical symptoms profoundly affect emotional adjustment. So interventions that actually look at these things holistically is important. One of the really groundbreaking studies that some of you may be aware of is the Smart Oncology series of publications. So they come from Scotland, and Michael Sharp's group has published extensively. So essentially what this is doing is delivering a very tightly controlled, manual-based depression care for people with cancer. So they take people who are very distressed. So they've got hospital anxiety and depression scores of 15 or more. These are people who are really moderately to severely depressed. They then do a structured diagnostic interview, and then they enter this program. So they have nurses, and they train these nurses very, very thoroughly. So nurses are participating in training probably for 3 months or more. They actually have to do quality control where they do videotaped interviews to show that they have the skill set. And then they see patients over a period of 4 months, and they have 10 sessions. It's a very heavily cognitive therapy biased program. It's very focused on depression symptomatology. So it's not focused on global distress or existential fear. It's focused on the depressive symptomatology. And so they're talking about restoration of pleasurable activities, structured problem solving and those sorts of things. They're then followed up, and so they have a regular automated review of their measures of anxiety and depression using the Patient Health Questionnaire 9, and that will prompt a psychiatrist consultation with the patient directly or a psychiatrist consultation with the family doctor to review their medication. And what this study has found has been really quite dramatic. They've had huge numbers of patients who've been very, very successful in reducing their anxiety and depression. During the duration of the study, the effect size was 1.13, which is absolutely extraordinary. And those patients also had better quality of life. Now, one of the things that I would note was this study focused very much on antidepressants. So the patients who were in the intervention compared with the control group, one of the focuses, it was an explicit focus, was to actually have them on maximal antidepressant therapy. And patients in the intervention group, 72% of them did have high levels of antidepressant treatment compared with intervention. Having said that, not everyone wants antidepressant treatment. And in this study, furthermore, 90% were women and very few had advanced disease. Gary Roden published an editorial in the Journal of the Lancet where this paper was published, and he raised the questions that this was very significant, but did we know the active ingredients? And that's the critical thing. This was a very intensive study. It was actually cost effective. However, is it the antidepressants? Is it the non-specific support and follow-up? Is it the problem saving and behaviour activation? And I guess the question is, are these interventions applicable in the real world? And increasingly there is attention on what are now being called pragmatic trials. Particularly in psycho-oncology, a lot of the data we have has been obtained from studies where a psychology master's student or other highly skilled professional is delivering a psychological intervention. Do we know if they could be translated successfully into the real world? And that is the big question I think that's important in terms of providing good care, because as David said, it's not just about buildings and bricks and mortars. It's actually about having a skilled and responsive workforce and maybe making more of what we already have. So I want to talk about a study, and we talked about this yesterday. It's the PROMPT study, and Sancha was an investigator on this study. So we were really thinking this was a real-world study. We wanted to see if we could actually train health professionals to provide a brief psychological intervention for depressed cancer patients. The Smart Oncology group provided very, very intensive therapy. We know that a lot of patients don't necessarily want intensive therapy, particularly if they're very unwell. It might be very difficult to attend. So we chose 4. It was an entirely pragmatic decision. 4 sessions, up to 30 minutes each. It really was how low you can go. Maybe we should have sort of subtitled it the ALDI intervention. Anyway, so essentially what we were hoping was that by doing this we could embed psycho-oncology into mainstream care and it would reduce stigma. The other issue I would say, and we did talk about this yesterday, is that many health professionals are placed in a position where they're exposed to vulnerable patients who express distress, and these health professionals say, I wish I had better skills. You know, the nurse who attends to a patient at 4 a.m, whose IV's tissued, who's crying and saying, I don't know what to say to my children. The physiotherapist who's doing lymphedema treatment, and the patient says, I've never told anyone else before, but I've been sexually abused as a child. So many of those health professionals say to me, how can I be better skilled? How can I better respond to these people? So in this study, we actually had a stepped wedge design. Now, at the time, this was highly innovative. I think that this was one of the first published studies in psycho-oncology where this method was used. When Damien Jolly, our statistician, mentioned the stepped wedge, I thought he was actually talking about a sort of shoe. But in fact, since then, it's actually become more popularly used. A word of warning, however, I think one of the big problems what we had was that one of the proposed sites was not able to become operational because of staffing issues. So if you're delivering an intervention and rolling it out using this methodology, you need to have capacity and enough sites that you're still adequately powered. But I actually want to talk about the philosophy of this study and how that worked and how that might have actually changed practice. So we recruited 44 health professionals. 37 completed all aspects of the training. So this was conducted at Royal Brisbane, John Hunter, Haematology Oncology Clinics of Australia, now called HOCA, and Monash Medical Centre. Now, to my knowledge, this is the first study of its kind internationally where we have trained radiation therapists, occupational therapists, and physiotherapists, as well as nurses. The average age was 42. None of them were particularly stressed at burnout or burnt out at intake. We allocated and screened patients, and again, this was a pragmatic intervention, so we took all comers. Over a third of our patients had advanced disease. Some of them were in the palliative phase. We recruited people providing we thought that they would survive 6 months or more. So we used the distress thermometer. Those who had low scores on distress thermometer and no risk factors for psychological distress received usual care. People who had some risk factors but weren't distressed or depressed using the HADS received what we call the low intensity intervention, which was a self-directed resource suite. All of those resources had been developed, were evidence-based. Many of them came from Peter Mac. Patients who got the intervention delivered by these trained health professionals were patients with a HADS score of between 8 and 21. Anyone with a HADS score higher than that was considered to be too depressed for this intervention, and they received specialised care. So if you look at most of the big drug trials, the big international pharma-run trials will recruit thousands of patients. One of the problems in psycho-oncology is that we're really only now moving beyond descriptive studies to intervention studies. In Lisbon at the International Psycho-Oncology Society meeting a couple of years ago, I actually did a quick survey of the abstracts, and of all the oral abstracts, fewer than 20% actually referred to interventions. So we're really at the infancy here. So by any measure, I think that this was a reasonable size study. So in the step wedge design using intention to treat, you actually compare outcomes for people recruited in the control epoch compared with people recruited in the intervention epoch. Now, we asked the health professionals to keep a diary of the interventions they provided, and I guess it's hard from a methodological point of view to think how accurately this reflects what actually happened. This is their perception. So you can't really appraise this, I guess, very rigorously. But what we found was that some of the health professionals used very complex interventions. They actually talked about legacy with patients who were terminally ill. They talked about opening up discussion with patients and with their families. A lot of what was provided was certainly very, very practical, and that probably fits in with people's background, professional training and discipline. Now, interestingly, these are the outcome measures, and what I will say and summarise to save you trying to read these slides is that this was a null study. So our primary outcome measure was change in HAD scores, and this study was not successful. Now I say, with no hint of bitterness, that we actually sought publication in 4 journals before this was published. I actually think I have a special place in psycho-oncology because on one occasion we were rejected by the editor within 2 hours of having submitted it. So what does that mean? I actually think it means that there's bias in publications. If this doesn't work, if it's too little, we need to know. So I think that, and this applies in pharma's trials as well. But we did some post hoc analyses. We thought, we're not letting this get away from us. So we looked to see, and we compared it with other studies. So the Smart Oncology only had nurses. So we said, well, do the nurses have a better outcome than the other health professionals? No difference. We looked at sites. Is there a difference across sites? No, there wasn't. We actually found that the more depressed people were, the more likely they were to improve. But you could say, well, that's regression towards the mean. But what we did find was that people with advanced cancer had improvements in their quality of life and improvements in unmet needs, health systems, patient care and support, and physical and daily living. And I think they're important results because patients with advanced cancer, I think, still are largely the Cinderellas of cancer care. Now, I want to talk about another emerging theme, and that is survivorship. So you heard the Minister say how fabulous health statistics are and outcomes are here, and increasingly we're seeing survivorship as a big issue, but many of these patients are not good as new. And until recently, the goals of follow-up have been trying to be vigilant about detecting recurrent disease. For a long time, our patients have been saying, what can I do to be well? And we haven't really told them, despite the fact that there are 2 big RCTs that show if you exercise after colorectal cancer, you may be at reduced risk of having a further recurrence. So what is a survivor? A survivor is considered an individual who's had cancer. And so the survival definition that's been used widely is from the National Coalition for Cancer Survivorship. And this is really taken from time of diagnosis through the balance of their life. I remember being somewhat surprised when I met people with advanced cancer who said, I'm a cancer survivor. But in fact, while you're surviving, while you're living, you are a survivor. So family members and friends are also impacted. So COSA has really shown a big innovation here. And after the Innovations Conference in Adelaide at Flinders University a couple of years ago, they convened a multidisciplinary working group. So that was in 2013. So the overarching mission was to improve the care of Australians beyond cancer treatment and diagnosis. So the questions were, what are the critical components of survivorship care? How can we deliver a minimum standard of survivorship care? And what do we need to do to progress this? So this working group, very ably chaired by Hariana Dillon with administrative support from Harley Griffin, looked at a number of issues. So the consensus was that survivorship care should be survivor focused. If we think about a lot of the care that is offered in acute hospitals, although we might like to think that it's patient-centred, in fact, many patients are slotted in and follow the protocol that we have for that particular tumour stream. So the suggestion was that these people had to have survivor-centred care and coordinated care. That care had to promote, prevent and manage. It had to be accessible and equitable. And I think the major innovation is looking at promotion and integration of wellness, not an exclusive focus on medical care and deficits. Now, in order to implement any change in health system, you have to have buy-in. You can't just impose things on people. And so there's been very broad consultation. Stakeholder consultation, COSA at the ASM had a survivorship workshop. This was again presented, a ratified model at the survivorship conference in February last year. The oncology social workers at their conference last year looked at this and provided further feedback, and there's been extensive consumer feedback. So the model, and this is a very, very sort of adapted and simplified version of the model, but essentially what it's saying is that we've got to have a tiered model. We need to look at people who've got very high risk, perhaps high risk of recurrence, high risk because of severe morbidity. I see a lot of patients with head and neck cancer. Many of those people have significant residual disability in terms of eating and in terms of body image. And we need to align follow-up and care depending on the level of needs. And that needs assessment must also incorporate attention to people's educational and rehabilitation needs. How often do we see patients who've lost weight and become deconditioned? I have a patient who has head and neck cancer who has lost 55 kilos. He has lost half his body weight. And I can tell you now, it'll be mainly muscle, not fat. So how do we help these people become rehabilitated? So really, we're getting to a point where we might actually have a model. So future work is really looking at how we develop screening tools, development of education and training tools, and really changing the mindset about what survivorship care should look like, developing performance indicators and identifying gaps, and seeing if this model really fits all groups, particularly, say, groups like adolescents and young adults. Now, I want to talk about further emerging themes, and one of the discussion points that we had yesterday, and I think is an important point, is how can we work better with what we have? I think that the number of patients who are depressed and anxious is significant, but all patients deserve access to people who are compassionate and who have good communication skills. Communication skills training was really advocated by the National Breast Cancer Centre. So when that was set up, they had a communication skills training working group. It was initially chaired by Phyllis Buteau. And the centre developed a number of evidence-based modules for communication skills training. They delivered train the trainer workshops. They really invested a lot of resources. I think that that did lead to systems change. The College of Surgeons, if you're doing breast cancer surgery as a subspecialty, you must participate in communication skills training. Medical Oncology Group of Australia mandates communication skills training for its trainees. However, how do we make this sustainable? How do we embed this? In Queensland, we've had a train the trainer model, and that was started in 2009. We looked at the evidence from National Breast Cancer Centre because what they found was that when they were training people, and this was intensive 2-day training, they often didn't go away and deliver workshops. Why was that? Well, I think it was to do with the fact that it was complex. People weren't entirely confident. And when you watch someone who is a skilled facilitator, it looks easy. It is not. Training people is actually hard work, encouraging people without crushing them, pushing them that little bit without crushing and overwhelming them. So one of the things that we decided that would be really important would be providing mentorship. So we actually have now trained 50 facilitators. So we've actually called for expression of interest. We've got people who already have highly developed skills, social workers, psychologists, and we've actually had intensive 2-day training to learn how to facilitate, and then we've provided mentorship. And that involved a big investment. Early in the program, I was going to Rockhampton, Cairns, Townsville, you name it, to run workshops with people. But now we've actually got this body of people who are trained, and so facilitators are providing training, mentorship for other people. So far, around the state, we've been able to deliver day-long training to over 500 allied health professionals. And these are not people in the southeast corner. These are people in rural areas. So I think that this is a model that really does build on sustainability and capacity. Now, 2 of the people who were involved in those early training workshops were Lyndall Gray and Jodie Nixon. And they have just been like a dog with a bone. They just won't let it go. And so they've actually developed a Care Express. It's a bit like the prompt, how low can you go? So the Care Express, because it's actually hard to get health professionals to commit to a day of communication skills training. Most health services really don't have capacity to release people for long periods of time. What we know about communication skills training is that it's the experience of participating in role plays, having the opportunity to rehearse, practice, get constructive feedback that seems to be an important learning point. You can't put people in a room over 2 hours and expect them to do role plays. People are too anxious, they're too scared, they're frightened of being humiliated. So the 2-hour express doesn't require people to do role plays. What it does is it actually uses videos with simulated patients, some of whom are actually staff, and it actually uses videotaped scenarios where people perform a role and then there's another role, and that's used as a point for discussion and perhaps improvement. So currently, Jodie's running a randomised trial where people are randomised to day-long training, usual care, which is a waitlist control, or express. And we will be looking at whether that does create change in people. Another way of building capacity is to actually look at our workforce and look at how we could further skill them. One of the discussions yesterday was, well, what do we do if we're in Broken Hill or somewhere else and we don't have people who have specialist psycho-oncology skills? Well, one of the things you can do is look in your community and you could ask people, are you interested in doing this sort of work? So we had a little bit of money from Queensland Health to do some video conferences, and these were with fairly senior psychologists who were experienced psychologists but who hadn't necessarily worked in cancer care for very long. So these were video conferenced and we chose people around the state. We had a discussion, what would you like to happen? What would you like to talk about? So these were case-based discussions, and we chose a series of themes that we would talk about. And the participants, there were only 6 psychologists, they actually chose a case and they presented a case each fortnight. We had these. Now, I think what was really useful about this was that I was the facilitator, which didn't mean that I told everyone everything that I knew, which in some cases probably wasn't going to be a great deal. But I think that what was very helpful was presenting a concise summary of the discussion at the end of that, sending that to participants. And because I'm in the situation where I have access to a lot of resources, I was able to send resources to those psychologists. So I was able to send, say, 2 or 3 journal articles or a literature review pertaining to that topic. And we know from general education that the timely educational initiative is one that's likely to have a very big impact. Now, this was a very, very small pilot study, but if you look at the dark colour, that's strongly disagree, green is agree, ochre is neither agree nor disagree, and I'm not sure why my little boxes so carefully placed have moved themselves along, exercising some degree of personal autonomy, obviously, and the dark purple is strongly agree. So if you look at the left, basically people are saying they don't have a lot of confidence in intervening with people with cognitive impairment. They don't have a lot of confidence in managing many of these issues. But by the time we'd finished this intervention, people had a lot more confidence. One of the things that came up very strongly is that people had a lot more confidence about the terminology. People who've worked in oncology for a long time, social workers, psychologists, pick up the language. They learn what the discussion is about. They learn about being on the 7th line of chemotherapy. They learn what pseudo-progression might mean. But people who are new to the area don't know. They don't know the language. Many of these psychologists were saying they didn't really understand what delirium was. They didn't really understand why people were doing these tests. And certainly it seems to me that that is a very simple initiative to build confidence and competence in people who are enthusiastic. Now, underpinning the prompt study that I mentioned was an earlier study called the CPAC study. So that was supporting and educating parents with advanced cancer. And it really came about as a practical strategy because I have a personal interest in parents who are dying and the impact of advanced cancer on families. And so in my workplace, if someone has a poor prognosis and dependent children, they would typically be referred to me. And it occurred to me that A, I couldn't see all of these people, I didn't have capacity, and B, they didn't need to see a psychiatrist. They needed to see someone who knew about stuff and who had some skills and evidence that they could share with them. So what we did was we actually thought, could we actually expand the capacity of nurses to provide this information and support? And in order to do that and understand that, rather than imposing something on nurses, we had a number of focus groups. And I actually came away feeling very sad and really a bit ashamed that I worked with these nurses and had no idea about the emotional burden that many of them felt, how unsupported they were. It struck me that nurses were asked to care for people who were dying and they had no specific training, they had no support, they had no access to supervision. Nurses said, I am scared I will upset them. I'm scared I will say the wrong thing. And if you drill down and ask most medical professionals, they will say exactly the same sort of thing. So what we did was developed an educational manual which was self-directed. And it was underpinned by theories of adult learning, and we included clinical problem-solving exercises. We included self-reflective exercises. And what we found, of course, was that there were significant improvements in confidence and competence. So we did a fairly rigorous evaluation. We did pre-training and post-training. It wasn't a randomised trial, it was pre and post. So we did structured interviews with simulated patients. So 5 minutes, mirroring real time. And we had a simulated patient, we had structured prompt, and the simulated patient had structured prompts that they had to give, including things like, it breaks my heart to think of not being there for the children. So this is a woman with metastatic breast cancer. And we evaluated the performance of those nurses prior to training and after training. And there were dramatic improvements in their knowledge and skills. There were dramatic reductions in practical responses. There were dramatic increase in self-care. Isn't that an interesting thing? Part of this training manual that we developed actually had a chapter on reflection and why this work is hard for us, encouraging people to think about how they deliver care and why it might be challenging for them. Clinical supervision is something that I think we haven't talked about often enough in terms of providing psychosocial care and expanding that. So in the PROMPT study, we had embedded clinical supervision that was in weekly format. I admit that I was actually somewhat anxious about the supervision. I thought that the health professionals would think, oh my God, I have to sit for an hour in a room with a psychiatrist and this will be boring as snot. But in fact, I would actually go over to see these therapists in the room we'd pre-booked. They'd be waiting outside. They could not get enough of it. Most of them were not familiar with the idea of clinical supervision. Most of them had never had an opportunity in a safe and supportive environment to talk about the struggles they would have with patients. It was conducted in group format, and it wasn't a matter of me or the other psychiatrist telling people what to do. Often the strategies came from other participants, and what was powerful was people being given permission to say things that were really important. So participation in this study has had ongoing impacts, and again, it's part of the metric. How do you measure an attitude when you've had a participant say that they are doing this sort of highly skilled stuff every day? How do you measure it when someone says, I used to just block people, I used to try to cheer them up, now I say, tell me more, what's happening? How do we measure that? It's very difficult. And there have been some systems changes. For example, in HOCA, which was the private oncology service, they've actually now embedded communication skills training for their nurses, which I think is a great outcome. Here's one of the participants. This is a physio. I think I use that every day. It's funny. Instead of just saying safe, you go, oh, PROMPT study. And it's somewhere in your head that kind of goes on. So, creating change is hard. If we actually look at the literature about how we embed psychosocial care, Penny Schofield did a very nice review, and you know there are so many models. I actually had a look at some of the literature, and it's sort of just mind-boggling. There are various models about how you implement change. I think it is important to look at the barriers, and they include people's beliefs and attitudes, the skills they have. Some things like reminders might be very helpful. I think personally, I don't know what's happened to my slides that were carefully proofread without the little interpolated spaces, for which I apologise. I think things that resonate for me are the link between evidence and practice. I work closely with nurses in my day-to-day clinical work. Nurses are bright, they're motivated, they want to do the best by their patient. But for many of them, this is a language they have not learnt. Nurses and GPs like to be given a framework. They like to be given a template, show me the way. So it's not a matter of I say to them, you say this. But when they see the words, that becomes real and authentic, and that is the opportunity for them to think about how they could model something like that in their clinical practice. Tom Hack in Canada has talked about this, and he's talked about the motivation and the true believers. I think what is important is he's talked about a critical mass, and I think most of us will identify with this. If you're in a place as a tourist and you're looking for somewhere to eat, and you walk down the main street, and there's a restaurant with a lot of people there, you're probably more likely to go into that place than the place next door where there is not a solitary diner. Because you think, well, they've voted with their feet, it must be good. And I think that there is part of that motivation. So as you actually get more and more of a critical mass, you will actually find that this changes. One of the things that we haven't looked at enough, I think, is patient advocacy. Many years ago, I was doing clinical work in HIV as a locum. Those were the days where mortality was dreadful. We would have 4 or 5 young men die every week. Most of them were gay. Most of their families had no idea. I treated a man who wanted to die because he was depressed. He'd come from a very active gay community in Sydney, and 27 of his friends had died from AIDS. AIDS is a different thing these days. My son teaches microbiology, and these students say, AIDS? Well, it's not a big deal. HIV? It's not a big deal, because we've made such progress. And I think the reason for the progress has been because of the political will of the population. So we should be harnessing the power of our patients with cancer, who after all are voters, to advocate for psycho-oncology. We know it's worked in breast cancer, where patients have advocated for access to Herceptin and other treatments. So the National Institute of Clinical Excellence has published quite a deal about how to implement change and what are the barriers. And there's access to educational materials. I think that we have to make them relevant, and I think the authenticity is important. Just telling someone that this matters isn't enough. You have to give them the tools to be able to operationalise it. They talk about patient-mediated strategies, etc. ASCO has now got some funding for an intervention. So this is funded by National Cancer Institute, and they're calling for expression of interest, sadly only open to US residents. So they're actually offering to take 2 people from each of 18 organisations and to have a 2-year structured program. So the workshop, I think in Florida next year, will be looking at distress screening, the culture of ethnic variation, communication skills. Those people will have quarterly video conferences afterwards to talk about the practical things in setting up screening. In year 2, they'll have a follow-up workshop and quality improvement, how to develop IT resources and how to market this, and then semi-annual conferences. I'm not sure what the budget is for this. I would think it would be considerable, but it's the sort of thing that could actually be embedded into existing conferences. I want to finish by talking about emerging conceptualisations. One of the themes that I think is really important is, for me as a psychiatrist, is why we do what we do. And I think that in my training of nurses and other health professionals, I've become very aware of the personal factors that make it hard for us to engage with patients, the reservation we have about hurting people. And I think that we haven't focused enough on our own sense of self and what our role means to us. So David's talked about self-care, and we do talk about self-care, but often that's in terms of a respite from our work, about having a break. I think self-care also needs to embrace who we are and what we do. And the concept of mind lines is being increasingly advocated. So the notion is that you give people information, but people don't act based just on that information. If you like, they internally digest it. They look for data that it resonates with, and they look for how it fits in with what other people have told them, people they trust and value. That whole notion of community of practice. And this is a theme that I think we should be focusing on more. Now, the concept of mind lines, I think, is really probably about 10 years old, developed by Gabay and May. But before that, a physician called Dennis Novak was talking about physician healers and a program they have in the States. And I think that what he says captures very well what my sentiments are. He's talking about medical students and health practitioners who are physicians, but I'm interpolating health professionals more generally. And he says, like soldiers on a battlefield, students must often deal with their emotions alone, or in chance discussions with colleagues and friends. Many learn to protect themselves and survive, but at the cost of distancing themselves emotionally from patients and peers, and consequently from the greatest satisfactions of clinical care. When they are not brought to the level of consciousness for health professionals, their personal attitudes, biases, fears, emotional reflexes, psychological defences and moods can interfere with their abilities to arrive at an accurate diagnosis, prescribe appropriate treatment and promote healing. Through a process of personal growth and the development of self-awareness, health professionals can realise their full potential for healing. Thank you.
Thanks, Jane. So we've got lots of questions up on our app, so please keep them coming. So let's just rewind a little bit here. Because I've not got a strong sense that there's an evidence base for interventions here from what you're saying. A lot of things work, some things don't. If I want to do something that I know works, for example, let's take the trial that didn't work, a very important result, a negative result was really important.
Well, it worked for people with advanced cancer.
Yes, but did it not work for others because, there's the whole issue of fidelity, how closely you stick to the protocol. For example, there's this disturbing statistic that research suggests is that the longer a psychologist has been in practice, the less they stick to the evidence base, and therefore potentially the less effective they are, which is why computers are sometimes better than therapists. Go on.
Well, I think the thing with the PROMPT study is it really was a pragmatic trial. And that is one of the issues. A lot of the interventions that have been shown to be effective, and they have, and you missed the HARC presentation and the presentation yesterday that showed that not only are they effective, but they're cost effective and in fact quite cheap to deliver. But a lot of them are very cognitively focused. Some of the earlier data about CBT showed that it was just fabulous. It was fabulous for everything. And more recently, some of that data is being challenged. They're saying the effect sizes aren't quite so big. I think for us in designing this trial, we wanted to look at something that was responsive to patients' individual needs. I think, and that's the challenge. If you have a manual that's CBT-based and you deliver an intervention, that's not really focusing necessarily on the patient's identified needs. And we were actually incorporating issues related to dignity therapy, supportive care, and those sorts of things. And you're right, it is very, very hard to capture that metric. If I think about this study, and that's why I showed the sort of interventions, I think probably we were never going to show an effect because we were evaluating small micro pictures of different sorts of interventions. It wasn't manual based, and that was the whole point.
To what extent have you studied what the psychologists would call bibliotherapy, in other words, knowledge?
Look, I think that there is some data that this can be quite helpful. And
we should just explain what that is. It's basically understanding your condition and the situation you're in.
And psychoeducation and those sorts of things. So I think there is some evidence for that. I would actually like to comment, some of the attitudes towards psychiatry and psychology have been that we're soft science. And I have to say the neuroimaging scientists are our friends because they are now showing things that we've said for years. People who've had early traumatic life events have structural and functional changes in their brain. People who've had intensive psychotherapy have structural and functional changes in their brains. So I think the traditional metrics we've had don't always show it, but I think there is evidence. I was actually at a big meeting recently in Geneva. The World Health Organization is reviewing their guidelines for management of pain, and Edward Brewer that was there, a great palliative care physician, and we were talking about evidence and lack of evidence. But at the end of the day, is someone going to do a randomised control trial to say you should be nice to someone? Not going to happen.
What evidence is there for environmental change? I'm thinking of power, the way you structure your clinic. In other words, can that prevent distress? What do we know? A lot of your presentation was on intervention. Mm-hmm. What do we know about prevention?
Look, I think probably not enough. David Kassane did a study of group support for women with metastatic breast cancer, and he found that the women in the intervention group were less likely to become depressed than the control group. How we prevent depression is complicated. There are certainly some things that we might do, like improving people's access to support, having an active coping style, those sorts of things. But I think there's not a lot of data that I'm aware of. There may be some, but I'm not aware of it.
Question from the Q&A side. By the way, there are standing microphones here at on the upper level and at the back here, so please come down to those microphones when you want to make a comment or ask a question of Jane. And then in terms of the also when we move to the panel discussion, which will be shortly. So the question is, how can we influence our patients to openly seek psycho-oncology support? So many of our patients in the older age group hold the belief that psychologists only see patients with disorders.
Oh, I think that that's true. I think we just model it and we break it down over a period of time. One of the techniques that I've used quite successfully, I stole from my mentor, Beverly Raphael, and that is what she called conspicuously loitering. So if you actually, as a psychologist or psychiatrist or social worker, maintain a presence around the clinic and just pop into the ward, when the referral's made, people say, oh, yes, I know her, I know him, I've seen them around. I think that we actually need to model to our colleagues how they actually facilitate that referral. If someone says to their patient, oh, well, there's not much I can do for you, you better see the psychiatrist, that's really hardly a ringing endorsement. So I think that if we can actually influence our colleagues to see that this is part of holistic care and put it on the table right from the outset.
Yes, question at the top. Yes.
Hi. Thanks, Jane. That was terrific. My name's Phil. I'm a cancer consumer, and I'm interested in understanding more about what you mean when you said people with advanced cancer are the Cinderellas of cancer care.
What I mean by that, I think it has changed, but certainly the focus in medical education and often in clinical contexts is that we're focusing on survival, which is a great thing, and cure. But if you look at media depictions of cancer, if you look at Breast Cancer Awareness Month, all of those things, they focus on early detection. They don't focus on the fact that people can die from their cancer. We don't talk about it. For women with advanced breast cancer, this is actually incredibly challenging. Many of these women will not die from their cancer, they will die with their cancer, but their life is changed. I have women who say, I'm living in the shadowlands. I'm not really sick, but I'm not really well. And that's why I actually read the words from Dennis Novak. I think the big challenge is that these patients threaten the sense of narcissism and autonomy and control of many of their health professionals.
Don't hold yourself back, really don't.
I see it. I actually have patients who say, I know I'm not doing well because the doctor doesn't spend long with me. And I think if we actually ask them, they would say that's true because we've not given them the skills to be able to deal with it, and it hurts them. They want their patients to do well, so they avoid it.
So Fran Boyle's going to be on a panel. She loves metaphors. So who's Prince Charming in the Cinderella metaphor? The medical oncologist. I don't think so. Another question online here is personalized individual needs based on psycho-onc services are unlikely to align to protocols and manuals. This is kind of what we were talking about a moment ago. Big RCTs don't generally test real world or include complex patients. How do we move forward to support and do more real world-like research? Close to your heart, that question.
Well, close to my heart, and as I say, I get the prize for the quickest editorial-based rejection. I think that we can actually mount some response to this. In the BMJ this year, Trish Greenhalgh wrote an open letter with support from people from about 20 countries protesting that the BMJ declined to publish a result that included qualitative data, saying it was of no interest. And BMJ said it's really of no interest and we're interested in big number studies, essentially. And I think that as a community, I think we can actually talk about this issue because it's important in drug trials, it's important in radiotherapy, it's important in all areas. And I think that we need to stand up and say, a null result is important. If something doesn't work, we shouldn't be doing it.
Talk to me more about single session treatment. I mean, there's a group in Melbourne called the Bouvier Group who kind of, they've looked at the data, and a lot of people, not necessarily in psycho-oncology, who turn up for care for their psychological distress only come once. And the thought's been, well, they thought it was crap and didn't come back. But in fact, when they're surveyed, they say, I got what I needed from that session. I got it, and I don't need any more.
Well, I think that's right. I think in patient-centred care, you provide what people need. They may come back and have more care later. I think one of our thinkings with the prompt study was that most of these interventions are very time-consuming and very intensive. There is some emerging evidence, Helen Christensen and others have published, to say that brief interventions may be effective.
The point they make about single session care when you come into broader psychological interventions is that you've actually got to think about it as whether you're the nurse or the psychologist, and actually make everyone as if it was the only one. So you've actually got to get through some stuff. So it's not just a casual encounter, it's actually a very structured thing. To what extent do we know what the structure of that, if it's going to be brief, should be, what you've got to get through?
I'm not sure. I don't know the answer to that, because for every patient I see, I have an hour-long appointment, and the first appointment is finding out who they are, the patient narrative. I can't do it in less than an hour and arrive at some sort of formulation of who they are. I certainly couldn't provide an intervention as well in that period of time. Although you might say that just listening is actually an intervention. And one of the things I found in the old days, Beverly Raphael would say, "Oh, could you just see this patient for me?" We used to call them Bev specials. "Can you just see this patient? I know her father, blah, blah, blah." And you think, "Oh, yeah, look, I'll just provide a consultation." And and then I can make a suggestion where they'd actually get some therapy. And I realised very quickly that once you saw them once, you were dead in the water. Really, they didn't want to go and see someone else. So I think that there is something that is hard to measure about connecting with someone who's interested.
What evidence is there that antidepressants make any difference at all in psycho-oncology? I mean, people say, evidence-based care for depression and anxiety is that if it's induced by bereavement, medications have really very little place.
Look, there's been a Cochrane review that said that antidepressants are very helpful. They're better than placebo. There are other studies that say that they're not so effective. One of the concerns that I have, and we talked about this yesterday, Australia has the second highest prescription of antidepressants of anywhere in the world, second only to Iceland. And in fact, we don't have higher prescriptions of other pharmaceuticals. So one of the concerns I have is that for many people, a prescription for antidepressants is given as monotherapy. And if antidepressants help, and I believe they do for some people, I think they save some people's lives, it's not here, take the Prozac and nick off. It's Prozac plus the psychotherapy.
And are there any ones that work better than others, or it's tailored to individuals?
No, I think it's tailored to individuals. One of my patients unkindly said, "You mean it's suck it and see?" And I guess essentially that's true. I can't do an algorithm. I can't look up EverQ and say, well, this chemo, this chemo, this chemo with antidepressants. So it is a matter of looking at their side effect profile. There are some of the antidepressants like tricyclics that are really helpful for people with pain, who are agitated, who can't sleep, but they lower seizure thresholds. So I'm not going to use those in someone with a glioblastoma.
To what extent can you predict people who are going to suffer distress?
Oh, there's quite good evidence. So women are twice as likely to become depressed than men. And that
irrespective of their pre-morbid psychological profile?
So there are some people who say that that's related to help seeking, but that's very clearly not the case. And the sex difference emerges at about adolescence. People who've been depressed in the past, single biggest risk factor for becoming depressed again. People who've got social adversity, people who've got financial strain. The higher the disease burden and morbidity, the more likely to get depressed. The evidence confirms exactly what you might intuitively think.
Yes.
Tim Luckett from UTS. Just returning to the prompt study and the better results in patients with advanced disease, I wonder if the baseline HAD scores meant something different in the advanced disease versus the earlier stage disease. We know that the HAD focuses on anhedonia, and could it be that really what was being shown in the patients with advanced disease was just natural sadness that people feel as they're approaching the end of life, and therefore they were more amenable to that sort of softer emotional support versus the kind of cognitive behavioural therapy that people with earlier stage clinical diagnosis would need.
It's the whole active ingredient thing, isn't it? We don't really know. So, I mean, I guess the issue of depression is complex, isn't it? And I think whatever the pathway, I see depression as a final common pathway. And so whatever the things that have led up to it, I see depression as a condition which will maintain its own momentum. Perhaps addressing some of those antecedents might help the depression. I don't really know, but I think depression is not one of a kind. I've never seen two people whose depression was exactly the same. Everyone has a unique story.
I guess my question really is, though, was some of those people really depressed in the clinical sense, as presumably people with earlier stage disease? Maybe the incidence of a clinical depression
we didn't do structured interviews on those patients, and I guess the issue about phenomenology and nomenclature does become an issue. There are some people who would say this is a normal bereavement response. I mean, if you're doing a randomised trial, you have to use some sort of structured measure, and that's what we did.
There's a question here. I think, as a clinician, what's the best way of dealing with family members who ask, who are obviously suffering distress? Often the person says here, often I'll tell them I'll call the team and they'll explain everything. But in fact, as a clinician, is that the only thing I can do, given they're not your patients necessarily?
Well, I actually think that the family members are partly your patients. David Kassane did a study of people with advanced cancer, and he found half of them were depressed. A quarter of their children were depressed, and a third of their spouses were depressed. So failing to respond to their needs means that they suffer, but it also means they can't provide the practical and emotional support for the family. Cancer councils provide telephone-based counselling for anyone affected by cancer. We should be saying to family members, you can call the cancer helpline. You can actually access some help.
Now, in other areas of care, you would enlist the family in therapy, in care. So, for example, children with eating disorder, you enlist the family for care, and there's good evidence base for that. Occupational therapy, physiotherapy, and other things in rehabilitation, you would enlist the family and teach them some skills. To what extent can the family become therapists?
I think it's complicated. I think psychoeducation for families is very important. I'm thinking of people like head and neck cancer patients. I see men with head and neck cancer who have no taste, who've had half their teeth removed, who are depressed. Their wife says, "What would you like to eat?" And he says, "Oh, whatever you think, dear." So she cooks a meal that would feed a third world village. He has a mouthful and says, "Oh, no, I'm not hungry." She says, "You'll never get better if you don't eat." And there's this terrible dyad where she's become, his carer rather than his wife. And I think in those cases, the psychoeducation and support and allowing her to stand back and see his needs rather than her own can be very important. I think when patients have more complex needs, it's hard to give a sort of generic response.